jobs, so that if you have a pre-employment examination, you can know that you're testing what the actual job requires somebody to do, and that somebody who applies for a job can do what they say they can do. And then there are lots of other workplace, cultural, environmental changes that can be made to make sure that you're compliant with the ADA, as well as doing right by your employees to decrease their risks of injuries. A couple of economic factors, because this group is so sensitive to that. For the first time ever, since some of the research groups have been measuring it, greater than 50% of working American adults are completely dissatisfied with their job and said that if something better were available, they would immediately jump to it. The actual statistic from one of the groups is 57%. So you're already starting with that uphill battle that more than half of everybody who works for you doesn't really want to be there anyway. So the likelihood of them having good lifestyle choices and behavioral choices that then support the fact that they feel good about themselves, like we learned during Mr. Allison's talk today, if they don't have good self-esteem, they're less likely to make the good choices that endorses them keeping good, healthy habits that then does lower your costs down the road. The problem is the current recession has made all of these factors even worse, so that first slide, the projected prevalence of obesity is clearly going to be much higher than what we thought it was because of the individual lifestyle choices that we've made during the recession. And we've got some data to show that. 1/5 of adults report health issues from the financial stress from the meltdown, even if they still have health insurance on your plan. So there's been a bimodal distribution. Some of them have thought, well, I may be at risk of losing my job, so I'm going to go get as much health care as I possibly can right now and stock up on medicines and do other elective procedures, etc. Others say, because I'm so worried about the co-payment and co-insurance piece of it, and if my spouse or somebody in my family has lost my job, I'm not willing to get the needed, important, necessary care that I need, which decreases the costs in your health plan this year, but could quadruple it next year when they end up in the emergency room with their heart attack, rather than just taking their $5 a month blood pressure pills and getting that stress test they needed this month, because they didn't want to pay the co-insurance co-payment. So you've got that bimodal distribution that has made it hard to sort out the data of what the true truth is. We know that more than half of people have lowered the quality of food that they've eaten during the recession, even though the percentage of our disposable income that we Americans spend on food is at the lowest point ever. We still have such a small margin of safety for what people save and spend in this country that they actually decreased their food as being one way they thought they could save money, so they didn't have to decrease their other consumption habits during the recession. And just during the first year of the recession, very clearly making that point that we've made poorer choices about our calorie density and our food quality, we need only look at the first year of the recession comparison stock charts of McDonald's on the top and Whole Foods on the bottom. Dramatic differences. Now, I know many, many, many more factors go into the stock price, but clearly the Wall Street's expectations of consumer patterns of behavior played heavily into our willingness to buy these stocks at certain price values, and it played out that way. Now, Whole Foods has snapped back a tremendous amount last year, as many other things did, but that alone is an indication of the change in pattern of behavior that's going to make all of these factors worse as it takes several years for poorer behavioral choices to play out in terms of first symptomatology and then real medical care that turns out to be real medical dollars on your plan a couple years down the road. So just one way of looking at how there's a multifactorial person that parks their car in your parking lot and walks into your plant every day, or your office building, or whatever your environment is. There are so many factors other than just the job factors at play when that person shows up that is a self-fulfilling prophecy of why this has been a largely immovable and impossible to change structure over the past couple of years. So for example, if we just look at some of the anxiety and the stress that the recession itself has caused, even among people who didn't lose their job and didn't really have a good medical reason to have a higher anxiety level, they tended to make poorer life choices. And sometimes I'll work with companies and look at their health cost claims data, either from their PBMs, from their pharmacy benefit managers, or from the health insurer itself. And always in the top 5 of all of the companies, and I bet it is in all of yours as well, somewhere in there are antidepressants, anxiolytics, which are anti-anxiety medicines, and some other psychotropic or mental health medications. I'm sure it's the case in your health plan too, but probably by a factor of 10, maybe 20, before people get to that stage and they go to the doctor and they get their Valium or they get their Prozac or whatever it is, they self-medicate for many years that cause these destructive health habits. And the 3 main ones are food, alcohol, and tobacco. Now, in the recession, the total amount of alcohol didn't change that much. It went a little bit from top shelf to middle shelf, no offense to any of the great Kentucky bourbon manufacturers who had a nice display yesterday, and hopefully they didn't get affected too much. And tobacco, we know smoking rates have consistently gone down. It plateaued a little bit during the recession, but overall trends have been to go down. But the one factor, as the McDonald's slide and some of the other data shows, that we have changed dramatically for the worse during the recession has been our food choices, the F. In fact, many of you may have seen just in today's Wall Street Journal, the Personal Journal has a great article explaining the neuropsychological reasons why some people eat because we need to survive, so they eat to live, whereas a larger component of society, because 57% of us hate our job, and because we have financial pressures, and because we don't save any money, and a list as long as your arm of other reasons why we have these anxieties and stresses, people eat as self-medication because it makes them feel better, and because it's cheap, and because you have to eat anyway, so you might as well just make a poorer choice with what you eat. So that's a great article if you grab it from the lobby and read that, as to where the science is going on this, to where now we're getting a dopamine high from eating for emotional reasons through habit, just the same way that cocaine and tobacco and other addictive substances can cause the same neurochemical changes in our brains, to where now eating can become an addiction to relieve anxiety and stress rather than for sustenance like it was originally intended. So what can you and your organization do in order to try to get your arms around this and at least know what your numbers are, if not dramatically cure it Monday morning? Traditionally, in organizations of any size, people as disparate as the cafeteria committee and the disability carrier barely knew each other existed, let alone sat down and said, what can we all do as a company to figure out what our cost drivers are and how we're shooting ourselves across the organization in the foot by having mixed messages and by doing the wrong things by our employees in order to get at these issues. And there are an enormous number of people around your organization who need to be at the table and who need to give you different pieces of information and data so that you can make better decisions with your benefit plans, with your other vendors, with your TPAs, with your health carrier, with whoever, so that you can get your arms around these issues and make some better choices and incentivize your workers or motivate and change their behaviors in the right directions so that you can make some improvements. Other things that we know must be there to be helpful. Anything that you adopt must be comprehensive. It must both affect the individual in terms of their own behavior structure and lifestyle choices. It also must be a comprehensive environmental, cultural change so that people feel supported in making good lifestyle and behavioral changes, and then they're not the only one, and that they're not being targeted because they're taking away from work time or they're doing some other kind of thing. A whole host of issues go into that. As I showed on the last slide, you've got to break down the silos across the organization and leverage your current resources. Now, your health insurer has a tremendous number of data-driven programs, projects, and things that they can offer to you and your workforce based specifically on the demographics and what you do and your geographic dispersal and a whole host of other things, including what's there. The one thing that I think is probably the single most underutilized resource that I'm sure you all pay for, but you're not using at